So I'm going to try and use some of Dr. Griffin's slides. I'm very sorry if it, for that reason, becomes a bit disjointed. Dr. Griffin works here, where that red circle is, in South Wales, which is a notoriously wet and windy part of England. It's famous for rugby. That is the Welsh women's rugby football team, I think, on the right there. And of course, the starting point of immunosuppression is the first successful kidney transplant performed remarkably more than 70 years ago now. And this transplant was performed without immunosuppression because the donor and recipient were monozygotic twins. They were identical twins. Since then, a huge number of transplants have been performed globally, and it's transformed the life of hundreds of thousands of patients with kidney disease. But one of the things that actually the pioneers of transplantation were very aware of was that transplanting an organ from an unrelated donor into somebody else led to a very vigorous immune response. And although they didn't know all the bits of the immune response, they knew sort of what it comprised. So they knew, for example, that there was what we would call on the left ischemia reperfusion injury, because you could see that on a biopsy. They knew in the middle that there was an inflammatory T-cell mediated response, which we now call cellular rejection, because they could see that on a biopsy. They perhaps were less aware that there was an antibody mediated response, because you couldn't really see that on the histology of the time. And we, of course, now know that the target of the immune response in almost all cases is non-self HLA molecules, and only very subtle differences can lead to a very vigorous immune response. And one important thing is that in humans, even in non-sensitized male patients, there is a very robust preformed cellular memory response to non-self HLA, and presumably that develops as a response to infections and so forth during childhood. So the immune response against, or the alloimmune response, is especially potent. And as I said, the early pioneers of transplantation were very focused on the cellular immune response, not an antibody-mediated response that we've been talking about earlier. And over the years, immunosuppression has changed, new drugs have come along, and the incidence of particularly a big step change here in the 1980s, and the incidence of rejection has fallen considerably, down to maybe 5 to 15% in the first year, and graft survival has improved consistently. Of course, all sorts of other things, particularly HLA typing that we've heard about earlier, and antibody detection have happened as well. One really important thing is all of these medications or immunosuppressive drugs were introduced into clinical practice based on really very short-term clinical trials. So outcomes demonstrating superiority of, let's say, tacrolimus to cyclosporin were based on trials reporting acute rejection at 6 months or a year. And one really important thing is, well, actually, what allows a kidney to last longer? And that's a very different question to what has less acute rejection. The thing that really crystallized how we perform immunosuppression now was this study, the Symphony study, which was a multi-center trial across many European countries. And it compared IL-2 receptor induction, mycophenolate and prednisolone in all patients with cyclosporin, tacrolimus, and sirolimus as the maintenance therapy. And the key message was that a 3-drug combination with IL-2 receptor induction resulted in less acute rejection, which you can see on the left, and better graft survival at 1 year, which you can see on the right. And that was maintained at 3 years post-transplant. So the tacrolimus arm is at the top there. So statistically improved graft survival compared to other regimes. So that really sets the idea that the most successful immunosuppressive approach was based on suppressing T-cell mediated immunity. It used IL-2 receptor induction, Critically, a calcineurin inhibitor, in particularly tacrolimus, to block T-cell receptor signaling, plus mycophenolate and steroids. So, how can we modify that sort of baseline approach to patients in different countries, patients at different immunologic risk, patients with different biologic characteristics, one of which you've heard about earlier. So I'm not going to talk about all of these things because this talk is an hour long and we have 15 minutes. So what induction immunosuppression should we use? I said that the Symphony study principally, well, focused entirely on interleukin-2 receptor blocking, but of course the alternatives are T-cell depletion. Thymoglobulin is widely used here in India, actually not in the UK. T-cell depletion in the UK is principally with the anti-CD52 monoclonal antibody alemtuzumab. And in the UK, we conducted 10 years ago now a very large trial comparing basiliximab and alemtuzumab. This is called the 3C study. And the important thing about this trial is that there were no particular inclusion criteria. Almost any patient could go into the trial, retransplants, first grafts. Their level of sensitization was not an issue, although they had to have a negative cross-match. And the important take-home message here was that acute rejection was substantially less with alemtuzumab induction, lower dose tacrolimus and mycophenolate, and no maintenance steroid at all. So not even apart from methylprednisolone intraoperatively. The more conventional regime is shown above, and actually acute rejection at 6 months there was relatively low as well. What is important is that in the long term, there was absolutely no difference in the outcome for these patients. It didn't matter which of these regimes you used in terms of 1, and actually we now know 3- and 5-year graft or patient survival. One interesting thing is that although the incidence of AMR was low, alemtuzumab does not apparently seem to suppress antibody-mediated rejection. It may even increase it a little bit. So based on that, in the UK, there are probably two widely used immunosuppressive protocols. The one at the top includes no induction, but long-term maintenance prednisolone. And there's a thing called the Osaka study, which is this albino one down here. That was absolutely no different to a regimen that includes induction. So 3-drug immunosuppression without induction, as long as it's based on tacrolimus, is a safe and effective regime. And that's important where the cost of biologic therapies may be significant. But the other 2 regimens are those widely used in the UK. So basiliximab induction and either quite rapid steroid withdrawal or low-dose maintenance, and T-cell depleting induction with no steroid. This is a more recent study. This is called the Harmony study. This was carried out in Germany, and it recruited patients until 2013. It was a relatively straightforward study that confirmed that used traditional 3-drug immunosuppression, that was arm A, rapid steroid withdrawal from a basiliximab-based regime, or rapid steroid withdrawal from a thymoglobulin-based regime. And the important thing is, all of these regimes were equivalent. It didn't make a difference if you used thymoglobulin or basiliximab, if you withdrew steroids or not. The acute rejection was very low, about 9%. There was perhaps better patient survival if you avoided steroids. Importantly, there was much less diabetes in the steroid avoidance group. There was no increase in DSA, but this was a very low-risk population of patients. They were not particularly sensitized. They never had DSA. They had a negative cross-match, and you couldn't include regrafts if they'd had acute rejection. So in low-risk patients, steroid avoidance or withdrawal is straightforward, whichever induction agent you choose to use. So I've sort of said all that already, so I'm going to move on. So these would be the two sort of current protocols widely used in the UK. So although we can get away with all of those regimes with similar short-term outcomes, is there one regime that allows you to promote long-term graft survival? And if you look at what causes kidneys to fail, probably 20 years ago, we would all have been saying, oh, it's the calcineurin inhibitor, they're toxic drugs, they're damaging the kidney. But actually, I think we now know that by far the most common cause of late graft failure, certainly in Europe, is chronic antibody-mediated rejection. And that's usually a consequence of under-immunosuppression, and I'm afraid in our experience, half the time it's because the patients just don't take their immunosuppression. And this speaks to what is an appropriate tacrolimus level. So we know what induction agent we can use, either. We know we can avoid steroids in the majority of patients. But if we do that, what should the tacrolimus level be? And this is a nice study from Manitoba where they looked at the sort of mean cyclosporin and tacrolimus levels over a long period of time. And you can see in the blue line here that the probability of developing a DSA was lowest in tacrolimus-treated patients as long as they had a level of around 5 micrograms per liter or nanograms per mil over long-term follow-up. And actually, these guys have published more recently experience with high-risk class 2 mismatched patients, and you can get the same result, but you need a higher tacrolimus level, so 7 to 9 micrograms per liter. So there's some suggestion that you might need higher tacrolimus exposure for high-risk patients. So I think in the UK, we're confident that we know what the standard of care should be. Minimizing steroids, aiming for as low tacrolimus level as possible, and avoiding T-cell depletion where those things are possible certainly may mitigate some of the adverse effects of immunosuppression, so infections and malignancies and so on and so forth. So is there a way of personalizing immunosuppression? Well, here are a few things that I think many people would think are reasonable. In the UK, we know that we know the EBV serology of donors and recipients, and we would definitely avoid T-cell depletion in a mismatch because of the risk of lymphoma. The benefits of avoiding steroids are obvious if you're at risk of diabetes. There are some people who might suggest you should maintain steroids for patients with glomerular disease. And there are some other things that perhaps are less important. All of these things here, in my view, there is no evidence that you should tailor your immunosuppression in any way. So older kidneys, damaged kidneys, kidneys with acute kidney injury, the idea of nephrotoxicity, I think that is probably a past concept. We should perhaps be tailoring immunosuppression based on immunologic risk, and the two key things that you've heard about there earlier are mismatch and DSA. And there's a lot of policies and guidance about this. Unfortunately, there is absolutely no evidence what immunosuppressive regime you should use for high immunologic risk patients, and that's because every trial of such patients includes 3-drug immunosuppression, very often with T-cell depleting induction. So it's very hard to say, oh, well, this patient is at very high risk. What should we do? And there's a very nice report from a group from Belgium and others discussing how going forward we should assess our immunosuppressive protocols and what might be a way to develop a more evidence-based approach, particularly for high-risk patients. So I'm going to stop there. I cannot say thank you very much in Welsh, but thank you for listening.